I'm Dr. John Raymond Baker, chiropractic doctor in Longview, Texas, and today this video probably is not so much for laypersons, it is for doctors and other healthcare professionals. In the 1980, an orthopedic surgeon by the name of Gordon Waddell became interested in so-called non-organic pain behaviors or pain symptoms or reporting, and he developed what's called the WADDELS signs. And I'm going to be referring to these documents a little bit because I wanted to quote some things to make sure that I didn't misquote or misrepresent. It was problematic in that the 1980 study that Gordon Waddell did, when it got released into the scientific literature, became a basis for workers' comp or for personal injury attorneys to attack a particular patient's veracity. That they wanted to say, well, you have a high Waddell score or several Waddell signs, so ipso facto you're malingering. And after several years, I think about 18 years, in 1998, Gordon Waddell just about had enough of it and wanted to address this whole topic and say to a lot of these folks, look, you're doing it wrong, you're using this wrong. I never meant for it to be used this way. And he wrote an article, an original study published that was entitled Behavioral Responses to Examination, a reappraisal of the interpretation of quote-unquote non-organic signs, close quote. The article was published in Spine, which is a refereed peer-reviewed journal. And in this new article, I want to quote what Dr. Waddell says, quote, despite clear caveats about the interpretation of the signs, they have been misinterpreted and misused, both in clinical context and in the medical legal assessment. The purpose of this article is to offer a reconsideration of their use and interpretation. Now, the original 5 Waddell signs included the following. A, tenderness. Organic causes of low back pain will elicit tenderness, and I'm quoting from this, pain upon palpation that's localized to the painful structure. 2 subtypes of non-organic tenderness were noted to include superficial tenderness, which refers to a pain response over a wide area throughout the lower back region when touched lightly. I will say, stress lightly. Non-organic tenderness refers to tenderness that is felt as deep, is not localized to a single area, and may extend to the thoracic or pelvic regions. And after I go through these, I want to kind of interject some of my own personal experiences and personal interpretations that I think are of value with regard to what Dr. Waddell said in his follow-up. Non-organic tenderness, non-anatomic tenderness refers to tenderness that is felt as deep, it is not localized to a single area, and may extend to the thoracic or pelvic regions. B, so that goes under the tenderness. B, simulation. If under the impression that they are undergoing a painful maneuver, patients may give a pain response. In actuality, the maneuver may not be painful. 2 subtypes are included. Cervical axial loading refers to pressing lightly straight down the patient's head. This should not aggravate low back pain, according to the original. Simulated rotation, a pain response when the examiner turns the patient as one piece without one part of the back twisting on another. Since the lumbar spine itself is not twisted, this maneuver should not cause low back pain. Kind of, how do you turn the patient as one piece without turning the spine? C, distraction. This refers to retesting a painful physical exam sign when the patient is distracted and unaware that a retest is occurring. In other words, if they're not paying attention that you're doing the same thing and that it's not supposed to quote-unquote hurt, they might not find it hurts. D, regional disturbance. This refers to a non-organic distribution of findings that cannot be explained based on our knowledge of neurology and anatomy. Two subtypes were described. Weakness refers to weakness in the region that cannot be explained on an anatomic basis. He puts a little more. Then sensory refers to sensory changes that cannot be understood on an anatomic basis alone. E, overreaction, refers to behaviors which are too dramatic to be explained by the injury in question. Such behaviors may involve sighing, grimacing, walking with a marked limp when no weakness is noted. And as noted in the 1998 article, which is Dr. Waddell's follow-up article to say, hey, you've been interpreting and using this stuff wrong, there were 3 specific caveats, warnings if you will. In the original study, they had to be considered before determining the patient had quote-unquote pain behavior or quote-unquote positive Waddell signs. 1, an increase in behavioral signs was associated with older patients, and the test was not recommended for use with elderly patients. Now, it doesn't say what constitutes elderly. Is 60 an elderly patient? Is 58 an elderly patient? So that's a problem I have with that particular line. However, it's clear that he's saying that someone that's 70 or 80, you shouldn't be using these tests with them, and you shouldn't interpret positive Waddell signs with regard to elderly. 2, it was emphasized that behavioral signs can and do occur with clear organic findings. The presence of signs, therefore, does not contradict. The presence of signs, therefore, does not contradict organic findings. And number 3, it was stressed that isolated behavioral signs should not be considered clinically significant. A patient needs to have at least 3 behavioral signs to be considered having quote-unquote pain behaviors. Even when a patient has at least 3 of 5 behavioral signs, it does not mean the patient's actions should be labeled as inorganic or pain behavior. Other important points made by Dr. Waddell in the 1998 Spine article include: conscious deception by a patient undergoing exam is thought to be extremely rare. Let me repeat that. Conscious deception by a patient undergoing an examination is thought to be extremely rare, meaning not common, not something you're going to encounter about every time you turn around. 2, positive Waddell signs can result from fear by the patient of the doctor or facility and from chronic or long-term decreased function. 3, the behavioral signs tests were designed specifically to identify behavioral responses in patients with low back pain. It should be recognized, however, that the patients with low back pain may have other problems. Neck pain or fibromyalgia, for example, may need to be considered as an alternate explanation for behaviors elicited in the context of an assessment of low back pain. In other words, look, if they've got fibromyalgia, they got neck pain, that might explain some of these different signs or symptoms. 4, behavioral signs testing should be could be carried out consistently by different examiners. Inevitably, however, a degree of judgment is required. This is meaning that there is a subjective component to this, that what I might think is extremes because I've never had that kind of pain, another examiner might look at it and go, no, that I would act the same way. Consistent differences among assessors in the number of behavioral signs found may illustrate inconsistencies in the manner in which the signs are elicited, unwitting bias, or even prejudice. So what he's talking about at that point is that the examiner, the doctor, designated doctor, whatever, may have a prejudice against the patient, against that condition or whatever, and insert some of that in his or her subjective evaluation of whether or not these signs are significant. I want to stress this one. Overinterpretation of individual signs is common. Overinterpretation of individual signs is common. The original article clearly stated that the test is designed to identify a pattern of responses to physical examination. I think that's pretty self-explanatory. Dr. Waddell indicates that even when there is clear, quote-unquote, clear evidence of behavioral responses to an examination, close quote, it must not be used to deny adequate and appropriate treatment for the underlying physical condition. In such cases, pain management as well as surgery may be necessary. See page 2370. Number 7, failure to recover from an injury should not necessarily be viewed with suspicion. Failure to recover from an injury should not necessarily be viewed with suspicion. An important and significant minority of patients become chronically incapacitated after injury, regardless of whether litigation is involved. Again, on page 2370. I'm going to repeat that. An important and significant minority of patients become chronically incapacitated after injury, regardless of whether litigation is involved. Regardless of whether or not you got a court case pending or you're going to get money out of it, there's people that are going to be chronically disabled by these or incapacitated by them. Other misuse or misinterpretation of the WADDELS signs is the medical legal context of traumatic personal injury occurs when the interpreter indicates the signs as deliberate or intentional faking. Dr. Waddell speaks clearly and forcefully when he states, quote, perhaps the most serious misuse and misinterpretation of behavioral signs has occurred in the medico-legal context. The signs frequently are used as an indication of faking or simulated capacity. It is certainly true that all sorts of behavior can be faked, and responses to examination are not exempt from this charge. As stated above, this is in bold print by the way, as stated above, however, behavioral signs may be learned responses to pain that have developed since the original injury and of which the patient is largely unaware. It cannot be assumed de facto that the signs are evidence of simulation for the purpose of financial gain. They are not a reason to deny appropriate physical treatment. Some patients may require both physical management and their physical pathology and more careful management of the psychosocial and behavioral aspects of their illness. The signs should be used to decide whether or not to offer treatment, but the type of treatment to offer should be used to decide not whether to offer treatment, but the type of treatment to offer. The behavioral signs are not on their own a test of credibility or veracity. Interpretation of the signs is only possible when within the context of a broader clinical and psychosocial assessment. And what I hope that you're getting to is that these signs are being used inappropriately. They're not the be-all and end-all to say this guy's faking or he's wanting to get on the dole, so he's making all this up. And in fact, Dr. Waddell's original concern, as I understand it, and I believe it's borne out by his 1998 revisit, is that these folks often may need something beyond just pain meds or beyond just therapy. They might need some counseling with regard to desensitization or pain management from a perspective beyond just physical. Okay, but he didn't mean to say, as I understand it, and I think you'll agree if you read the 1998 paper, that it wasn't ever meant to be used as, well, he's got these signs, 3 out of 5, he's got to be faking. That's just totally incorrect, and Dr. Waddell pretty much cleared that up in his 1998 restatement of his signs. The authors recognize the fact that a finding of overreaction may be biased by the observer. Overreaction may be biased by the observer. Furthermore, they realize that even with a proven and treatable physical lesion, persons with multiple organic signs may need psychological assessment. Finally, the authors caution that these signs do not substitute for a standard psychological evaluation. Unfortunately, various court cases resulting in denial of work comp benefits, workers' compensation is what it says, contain unchallenged expert testimony that a positive result on Waddell's testing demonstrate symptom magnification, negative findings, and exaggerating. So basically they go on to say, well, that you shouldn't be doing that. So that's one thing I wanted to go over in this video, was that Gordon Waddell, who came up with the signs, are saying, look, you are not using them correctly. They were never meant to be used the way you're using them, and pretty much stop doing it. Now, there's other things that have to be filtered or figured into this equation. One is that there is a cultural component to pain sensation. In other words, the Native American Americans, were often taught as children, the males, to be stoic and to take a lot of pain without showing it. That's one example of a cultural bias, that they reacted to pain differently. They might not show pain, even though they're hurting inside, they're feeling it. Okay, number one. Number two, there are some studies that show that someone with chronic pain has a level of perception of pain. It doesn't take, I'll say it this way, it doesn't take as much pain to set off their feeling of pain as it does someone that's not, chronically in pain. If you're hurting all the time, it kind of sensitizes your system to pain. Now, the other side of it, somebody might say, well, yeah, but don't you get used to pain if you've had it a long time? Not necessarily. Again, you have to understand that pain is not the same for every human being. That some people can have the kind of pain that would cause others to scream, and they just they have a high pain tolerance. I mean, that's a term that we in the healthcare field have come to recognize, that there are genuine differences in people's sensitivity to pain. Some people will almost scream at what would be a slight level of pain for someone else. So that has to be part of the whole scenario. Is number one, do they have a cultural interpretation of pain, and the authorization, this is okay to show that, oh, I'm really reacting to pain. Is that part of their cultural orientation, number one? Number two, pain sensitivity varies greatly from person to person, even within a culture. You might have two Native American braves back in the 1800s, and one can take a lot of pain, the other one can't. And it might be, to some extent, a genetic predisposition, that one person doesn't release as many noxious chemicals as the other, that they're just not built to feel pain a lot. And then on top of that, there are certain physical conditions where people cannot feel pain. In fact, there are people that have had slight injuries to their foot that turned gangrenous because they didn't hurt. They didn't know that their foot was hurt. So there are physical reasons not to feel pain as much. There are cultural reasons. There are individual variations, and also whether or not you have chronically had pain for a long time. And those have to be figured in, even with WADDELS signs, And then on top of that, I think it's very important that Dr. Waddell included the bias of the examiner, that a doctor who may not like the person, I mean, we all like or dislike people often on our first encounter, and if you don't like the person and you think that, oh, they're just trying to be on the dole, you might be, since you're the examiner, you're the tester, you're the finder of fact, you're liable to say, oh, you're overreacting, and write that down. Oh, look, there's one of the WADDEL signs. You're not, your pain levels are not in the right area. There are a lot of things, including MRI findings, whether or not this person has trigger points, because we know that trigger points, myofascial pain disease, will cause, if you press here, it's going to cause a distant pain to be felt. That's why it's called trigger. You press this and it triggers a pain response in another body part, which someone who's not versed in trigger points might go, oh, that's inappropriate. I pressed them there and they're hurting in the low back. So we have to consider all these things with regard to WADDEL sign. And if you read all these documents, as I did, and read the 1998 paper and some other people who have spoken at length in a scholastic fashion about Waddell sign, you realize that saying, oh, they're symptom magnifying or they're quote-unquote malingering is really an inappropriate use of Waddell signs. And Dr. Waddell made it very clear in 1998. And apparently, some doctors, some healthcare providers, some insurance people don't get the message. And I don't know how much clearer Dr. Waddell has to be, but I do think that everybody that wants to interpret Waddell signs should be mandated to read his 1998 paper, because he does make it clear you're not using these 1980 signs correctly, and you need these caveats that I've included when you're trying to use these as guidelines to decide whether or not someone is acting appropriately or not. So I hope I didn't bore you too much. I think it is important in that some people are being denied treatment because of these alleged Waddell signs. Have a great day. Thank you for listening. Bye.